Imagine a patient with a diffractive trifocal lens in both eyes, multiple radial keratotomies, but a history of chronic headaches and an increasing intraocular pressure on one side. Despite seeing 4 different ophthalmologists, this patient's diagnosis remained elusive for the 63-year-old lady. Hello, my name is Professor Sorcha Ní Dhubhghaill, and in this video we'll explore how we tackled a complex case and successfully performed an IOL exchange in a tricky situation. When we saw her autorefraction, she had a mean spherical equivalent of 0. And that's very difficult to achieve in radial keratotomy patients. Minus 0.25, it's excellent. She had been diagnosed with pigmentary dispersion, which is a condition associated with a high rate of glaucoma. So that was a worrying issue. But when I performed her aberrometry, which is a test I often do in these cases, patients who are, we call 20/20 unhappy, are excellent cases to perform aberrometry on because it can show you visual complaints that you can't see at the regular slit lamp. But on the infrared image on her aberrometry, we discovered something a little bit different. And if you see on this pupil, there are dark moth-eaten appearances around the central ring of her pupil. And in the periphery, you're seeing these dark spots too. But when I took her to the slit lamp and performed a very simple retroillumination, we see that she has vast positions of loss of iris pigment. So she doesn't have pigment dispersion syndrome. She actually has HUG syndrome, which is not a natural development in the iris, but in fact, a response to the implant lens she had. The moth-eaten appearance around the iris was actually coming from the fact that the trifocal lens was a bit too far in front. As the iris got big and small, it acted like a cheese grater, so that iris kept coming out and out. So it changes your decision between, do we take a risk with this good refraction, to you have to take that lens out. This is an ongoing active glaucoma risk, so you no longer have to sit on the fence, you have to take action. The YAG capsulotomy is important because all patients who have had a YAG capsulotomy have an opening between the anterior and posterior segment. You have an incredibly high chance of having vitrium coming forward. Usually, your biggest challenge in an IOL exchange is loosening the IOL from the capsular bag. So I have a huge advantage here that it's already loose, but I want to protect the anterior vitrium. I go underneath the lens and I create for myself a cushion of OVD that pushes back the vitrium, and I do not need to use an anterior retractor in this case. I lift the lens into the anterior chamber, free it away from that posterior capsule, and I create a larger incision than usual. The trick here is I have to avoid the radial keratotomies. Radial keratotomies can split, and then you have an irregular and open cornea you have to stitch. So once I create the incision between the 2 keratotomies, I can get cutting my IOL. Some people have a preference to do a small radial cut, to do a Pac-Man removal. In this case, because it's a plate haptic, it's pretty big, I elected to take a half cut, rotate, and complete the cut from the other side. Then I have 2 nicely mobile, but quite large pieces. This will help me get those pieces out through the 2.8 millimeter incision I've created. And it gives me enough space in the incision to get the new lens in. The good news for her is, had it been a typical pigment dispersion, this would continue to evolve. But by taking out the problematic lens, we actually return her back to her intraocular pressure, and the chances that it will evolve have been eliminated. What she had been feeling was the lens haptics pushing in the sulcus. And because she had difficulties finding the words to describe it, it had led it to be a diagnostic challenge. So when a patient tells you it's not right, you really have to dive into it and resist the urge to give another dry eye drop. From the point of view of the pain, she's satisfied. From the point of view of the pressure, she's satisfied. From the point of view of the refraction, she's not satisfied. The sulcus lens I placed left her further into the minus. So she's now minus 0.75 mean spherical equivalent with a slight irregular astigmatism. While I might be happy with that, she had better vision with her problematic lens. And this is just a journey we had to go through together. So I think there's two key take-home messages here. Number one, diffractive multifocal lenses are not designed for the sulcus. And not only can they give rotational problems and reduced correction, they can also give this iris cheese greater effect and create these pigment problems. So that's number one. If you're not sure your bag is intact, don't put your multifocal lens in. The second part is indeed trying to put the patient's symptoms into an objective measurement, because patient's symptoms alone can be difficult to advise one course of action versus another. But once you see on the aberrometry and you see on the retroillumination, that lens is in the sulcus, then you have a much firmer ground to stand on when you make your advice to the patient. There are simple cases and there are complex cases. If a lens is located in the sulcus, it's relatively easy to mobilize. The more difficult issues when you're starting with IOLs is the length of time that it's been in the bag. There will be more capsular fibrosis and adhesions the longer the lens is in place. The second problem is whether they've had a YAG capsulotomy. This not only creates an opening for vitrium to come forward, it also makes it more prone to tearing, ripping, and dropping the lens. So if you can do it without having a YAG capsulotomy, or if you think a patient might need a lens exchange in future, don't YAG. The third thing is you need to know the lens material and shape. Lenses cut differently. Hydrophilic lenses cut more easily than hydrophobic lenses. Silicone lenses cut very easily. And I'll tell you, don't cut a PMMA lens at all. I've tried it once, I broke my scissors and the lens remained intact. So be very aware in identifying what lens was placed if you can, and be prepared to cut or fold the lens in the eye and have a very safe explantation. Conversations with the patient about what lens to put in is very, very important. You need to have, or at least I usually prepare 3 options. The first option is an in-the-bag lens placement. The second would be a sulcus placement. And the third would be another placement, which would be non-capsular bag-located lenses, either an iris fixation or a sclerofixated lens. There's also an important 4th lens option, which is no lens. It is always possible to tell a patient, I'm going to stop here. It is not safe to continue. There will be no patient that says, no, go on, keep going. Every patient wants a safe and long-term quality outcome. And if it requires a second approach at another time, that's allowable and wise.